சரி ஒன்றும் இல்லை.
Okay, doctor.
Sir.
So
I see
what were your observations, doctor?
Sir, I see a 7-year-old male child attached to multiple monitors, probably in a drowsy neurological state with multiple skin lesion, probably bullous skin lesion which has ruptured, involving the mucosal surface like oral cavity, and I see multiple lesions on the chest and lower limb. He's also connected to 2 IV cannulas, so probably I would at this point my differentials would be a dermatological condition like
Yeah,
Stephen
doctor.
Thompson's.
We can proceed with history. So, what questions will you ask in the history?
So, in the history, I would ask for history of any infection, recent history of any travel. I would also ask history of any drug intake and the adverse reactions following any drug intake. Any childless whether suffering from any other dermatological conditions congenitally. And I would also consider asking any history of arthritis or other systems involvement other than the skin.
And then, doctor, that's all. Are you there, Dr. Anjali? Dr. Anjali? It's not audible for me. Am I audible?
Yes, sir. Yes, sir. Yes, sir.
Dr. Anjali, are you there? Yeah, now only you are audible, doctor. So, somewhat voice is dragging. Okay, so meanwhile, Srikanth, do you want to give a try?
Yes, sir. Yes, sir.
Okay, so what do you want to ask in the history, Srikanth?
So first of all, I would like to ask about onset and duration, whether the lesions are progressive or subsiding during the period, and I will ask about the characteristics of the rash, whether it is associated with the itching or any other systemic illness like fever or any cough and cold. And the drug history also I would like to ask, and immunization I will inquire about immunization history. Anyone in the family is suffering from the same similar complaints, I will ask. Yes, sir, that's it.
That's it. Okay. So what will you examine in this child?
I would like to examine the rash complete skin examination and head to toe examination, physical examination including pallor, any other on examination findings, and abdominal examination also. I will look for pulse rate and blood pressure also.
Okay. Anything else?
Respiratory system examination, because I have observed he is coughing in the video.
Okay. So what is in your differential, doctor, now?
I can see target shaped lesions and My differentials are maybe due to Steven-Johnson syndrome or uh, toxic epidermolysis 10 necrosis, or else drug eruption. It could be yes, sir, SJS 10 and a drug eruption. Maybe bullous impetigo, staphylococcal skin scarlet syndrome. These are my differentials.
Okay. So, which will be in your topmost differential among these?
As I see, both the skin and mucosal involvement is there. I can keep my topmost differential as a Steven-Johnson syndrome. If the severity is more based on the systemic illness, then I will opt for 10 toxic epidermolysis necrosis.
Okay, doctor. So, assuming that how will you clinically differentiate Steven Johnson from staphylococcal scarlet skin syndrome?
Mm, yes, sir. Based on the skin lesion, sir. By rubbing the skin lesion, it will slough off. In staphylococcal skin scalded syndrome, it won't happen in SJS.
Okay.
Nikolsky signed positive in SSS, staphylococcal infection.
Okay.
And peeling also we can see.
Okay.
Mm,
Okay, doctor. So, assuming that this is a case of Steven Johnson syndrome, and okay, so how do you want to investigate this child, doctor?
I would like to send a full blood count and electrolytes and blood glucose also, and skin biopsy, punch biopsy, renal function test. Yes, and swab, skin culture, skin swab also, and blood culture also. I would like to send. Mm,
Okay.
That's it, sir.
Suppose it's staphylococcal scalded, where will you take the swab?
Mm, mm. From the lesions, sir.
Okay. And regarding management, how do you want to manage this child?
First of all, I would like to involve my team, including a pediatric consultant, and I will take the opinion from dermatologist also. And my main aim of the treatment is support to treatment and wound care, pain management, and I will prescribe antibiotics if is there any secondary bacterial infection. And I will try to hydrate the child properly. Mm, Yes, sir. Electrolyte, I will correct the electrolyte imbalances. I will check, I will monitor uh, pulse rate and blood pressure also to prevent the shock. So main aim of the treatment is supportive care, preventive the shock and wound care and pain management, sir, and prevent the secondary bacterial infection by giving IV antibiotics.
So
And
what?
if it is due to the drug, then I will try to remove the drug.
Okay, very good. And what any specific what complications you expect?
Complications, secondary bacterial infections, sir, and shock and sepsis, septic shock,
Okay.
and it can lead to it will transformed into 10 possibilities there.
Okay. Okay, doctor. Time up.
Renal failure also. Yes.
Yeah. Time up. And okay. So how you did, Shrikant?
Suddenly I have taken this
Yeah.
station,
Hey,
unfortunately, but I think I'm unable
I
to
think we should
differentiate
be
the.
ready. We should be ready always for
Yes,
exams,
yes,
right?
yes, sir, yes, sir. I think I am unable to differentiate between staphylococcal and SJS. And swab also you have asked. I am not sure about that. I think maybe I didn't remember. I remember the question, but answer I didn't remember the answer.
Yeah, yeah, yeah.
I think mucous membrane involvement is the main difference, isn't it, sir?
Yeah.
There's no mucous
Yeah.
membrane involvement.
Yeah, so the involvement, so mainly the involvement plus the progression. So it starts with the redness, tenderness, so pain, then the sloughing starts in staphylococcal. So in staphylococcal, no, it starts with the erythema, then pain, then the lesion will come. So the pain is very important. Well, SJ starts straight away as bulle. Okay. So that and mainly the flexural region, the staphylococcal will be more in the flexural region. Okay, and mucosal involvement, main difference is mucosal involvement. So it will not be there in staphylococcal scalded, but in SJ you will have the more than two and more than two mucosal involvement. So eyes, mouth, then genitalia. So even the respiratory here, the child was also coughing actually. So respiratory involvement, it's all possible. Okay. Then anything else others wants to add to what Dr. Shrikant said?
That
So you
could
asked
be
about
meningococcimal rash.
Doctor?
Sir,
so
could
you
it be like meningococcemia?
Yeah. So the meningococcemia you should be differentiating, no? So that will not be in the bulle type, no? So we
Yes,
are
sir.
not supposed to give
Petica purpuric rash.
peticulae, ecchymotic, purpuric, no? So like that only the meningococcal. So we should not give
So
here
the DDs.
meningococcal.
Okay,
Yeah,
sir.
doctor? DD.
So DDs
One
here
of
is
the DD I have missed
SSN
dress
and
also, sir.
SSS. Sir.
Yeah, I think everyone asking about the DD. So most important will be the examiners will be expecting about Steven Johnson, toxic epidermolysis necrosa. So these two are important. Then staphylococcal scalded skin syndrome. So in MRCPCH, they want mainly whether you are differentiating staphylococcal scalded skin syndrome from Steven Johnson syndrome. So that is the most important they are expecting because the treatment modality will be different. Here in staphylococcal, straight away you have to start antibiotics. There you are giving antibiotics only for the preventing the secondary infection. But here you have to treat the staphylococcal. It's a toxin mediated. So that is the most important differentiation. And I think as Shrikant said, if the child is very small and it could have been for a long period, every time going and going, no? So epidermolysis bullosa also we should keep in mind. So congenital,
Dress also, no, sir. One more differential is dress.
yeah. So you can keep that. And erythema multiforme also can be kept. That also will go very close to Steven Johnson syndrome. They will also have the target like lesions. So, but major they expect you to differentiate between Steven Johnson and staphylococcal scarlet skin syndrome. Okay.
Please, sir, can you go over the differences again? I didn't really get it very well, please. Sorry, please.
So
Thank you.
differentials, we would like to mainly differentiate Steven Johnson syndrome and 10 plus staphylococcal scalded skin syndrome. So these three are very must. You are not supposed to miss. Plus the fourth, maybe since it's a bullous, so congenital bullous lesions we should keep in mind. So epidermolysis bullosa we can keep. Then fifth is the erythema multiforme. So that is also coming in the spectrum of Steven Johnson syndrome. So these things and dress, I think Shrikant has kept it in the drug induced. Okay.
So, what are the major differences between SJS and scalded skin syndrome? I mean,
Yeah.
what's
So
the major?
so the major differences I think is the mucosal involvement. So more than or equal to 2 mucosal involvement will be there in SJ syndrome and 10. And in staphylococcal skin syndrome, mucosa will not be involved. So here the child's mouth is involved and also eyes were also involved. Okay, so that is the most important difference. Then when it comes to the presentation, the staphylococcal starts with an erythema, then painful, then mostly in the flexural region. That will be mostly in the flexural region, and it starts with an erythema and pain. Then the bullous lesion starts. So that is very important. Then what triggered? So here in SJ syndrome, you have a history of drug intake. So drugs might be the most common culprits. So there might be some ingestion of anti-epileptic drugs or penicillin and sulfonamide drugs, most important sulfonamide drugs, and sometimes infection. So mycoplasma and HSV, herpes simplex. So there may be a trigger for SJ syndrome, but staphylococcal straight away it will be from staphylococcus. So it might be the lesion might be in the nose, a small furuncle, staphylococcal. So that will be the source. From there, the toxin, and that's why Shrikant, I asked so where you
Yes,
will
sir.
take the swab. So on the lesions, you will not get the staphylococcus because it's toxin mediated. So you have
Yes.
to take mainly from lesions like the nasal swab. So there only it will work out for staphylococcal. So where will you take the swab means nasal swab will be a better answer rather than the lesions. You cannot take staphylococcus from the bullous lesion because it's a toxin mediated. You will not get any organism there. Okay,
Even oral from the oral swab.
Okay, sir.
doctor?
Oral swabs also can be taken for staphylococcus.
No, it depends upon the focus. So where the focus is. So where the staph. So it might be a small furuncle or carbuncle. So there only you have to take culture. You cannot take from the all over that staphylococcal scalded bullous lesion. No, if you take, you will not get anything because it's a toxin mediated. So that is the thing which important. Then another thing which Shrikant we were discussing is the Nikolsky sign. Nikolsky sign is positive in all the three types. So you cannot
Okay, sir.
differentiate the three based on Nikolsky sign. But yes, histopathology will help you out. So in Stephen Johnson, it will be a full thickness lesion. But staphylococcal scalded is a superficial epidermal separation. So that can help you differentiate. And the treatment modality. So here, Steven Johnson treatment is most often like supportive, as you said, supportive, and maybe sometimes IVIG and some prefer steroids, but supportive treatment is the most important. But staphylococcal scalded, antibiotics straight away, especially clindamycin has to be started. So this is the major difference among three. Then mortality. Staphylococcal scalded has a better mortality profile than Steven Johnson. So and Steven Johnson 10, how will you differentiate depending upon the percentage? So remember 10 is not 10 percentage. So 10 will be around 30 percentage and Steven Johnson will be less than and around 10 percentage. So how much involvement based on that only Steven Johnson and 10. So 10 will be somewhere more than 30 percentage and Steven Johnson will be around 10% involvement. So mortality will also be like 10, you will have a higher mortality, Steven Johnson less mortality. And staphylococcal, if you have identified, you have started the treatment, better mortality profile. Okay. Any other inputs anybody wants to give? So here,
Sir, please, can we also take swabs from Stephen Johnson as part of the
Steven
investigation?
Johnson, here punch
Just
biopsy.
maybe for superimposed bacterial infections.
Yeah. So Steven Johnson, mainly we are taking the biopsy for secondary infection. So secondary bacterial
Yeah.
infection, wherever you feel it is erythema, wherever you feel
Okay.
it's infected, you take there itself the swab. Okay.
Yeah.
And
Okay. And
biopsy,
sorry. Okay.
punch
Yeah,
biopsy.
just one. Okay, punch bio. I mean, do we need to involve pediatric intensive care unit as part of our management, MDT, apart
Yeah,
from dermatology?
multidisciplinary team, who are all we are going
Yeah.
to involve, multidisciplinary team. It's like a burns. You are going to take care like a
Okay.
burns. So you will
Okay.
involve the pediatrician, you will involve the dermatologist, since it's a skin dermatologist, then eyes have to be taken care. So ophthalmologist will be there.
Yeah.
Burns, so plastic surgeon you have to involve. then the physiotherapist, then here infection, so microbiologist for the swab.
Okay.
So multiple teams you have to involve actually. Yeah. And with regards to the feedback, if I would say, how you are going to start. So there is a question, is this a clinical diagnosis, right? Yeah, so clinical diagnosis, yeah, but final confirmation, we need a punch biopsy. So you do a skin punch biopsy, so that will give you the diagnosis. Yeah, physiotherapy, yeah, you have to protect from contractures. So the important complication of this whole burns is contractures. So now the child will be not mobile. So complex scarring and contractures will be a problem. So physiotherapy has to be kept here. So most important in history, I would say, is the regular onset course duration you're going to ask. But distribution of the rash you're going to ask. Most important history will be the mucosal involvement. Whether mouth is involved, eyes are involved, how is the genitalia? So that thing you're going to ask. To rule out whether it is staphylococcal, you're going to ask the history of redness, pain. So that part you're going to ask. Then the incriminating component. So any history of any fever, then drug intake. So you want to rule out whether it is infection induced or drug induced. So any history of any drug intake or the infections, and how severe is it? So how is his activity? How is the urine output? How is his intake? So that part you are going to ask. So this is the most important in the history. Then once it comes to the examination, the usual airway, breathing, circulation, the vitals are very important. They can go in for shock at any point of time. So they are like burns. Then you're going to describe the rash. You're going to fully describe the distribution. Especially you can ask about Nikolsky sign. So it's like pressing and looking for separation of the skin. Then you are going to special mention of how is the eye, how is the mouth involvement, and other mucosal involvement you're going to ask. Then maybe some sensorium assessment you can do in the examination. Then when it comes to the investigation, I think most important will be the skin punch biopsy plus the septic workup, because chances of infection is there, septic workup, and the nasal swab or swab from the blister. Then the regular urea creatinine electrolytes and LFT. So that is important. Then when it comes to management, the multidisciplinary team, remember to involve the ophthalmologist. So sometimes we'll forget. So ophthalmologist, the burn specialist. So all those you try to involve. Management, yeah, it is going to be supportive management. So remember to address like a burns. So volume resuscitation is very important, and protecting the child from infection is very important. So reverse isolation is very important. So you have to protect the child from others. So the health personnel should not give infection to the child. So you have to do the reverse isolation, preferably in a positive pressure room. You have to keep wound care just like a graft, like a burns. So you need the plastic surgeon input. And pain management, you have to give the pain. Then you have to protect from secondary infection, for that antibiotics. And remember, the mouth is involved, so nutrition is going to be an effect. So dietitian also you have to involve. So this is the major thing. Supportive treatment is the major thing. Plus IVIG, some institutions prefer even giving steroids. So, but the major thing will be your supportive management. Okay. So any other doubts, or we will move on to the next video? So can you please show the clinical shot? Yeah.
What did
The
you say about the reverse
isolation.
What is
Yeah.
that?
Yeah. Reverse isolation is the one where usually isolation we do why? To protect ourselves from a infection. Suppose the child is a multi-drug resistant TB, the patient is having. So to protect from them, from others, you isolate them. But here, the child is vulnerable. So to protect the child from us, you're isolating. So that is called, so you have to wear proper personal protective equipment. So that all you have to follow.
Barrier nursing?
Yeah.
Barrier nursing in this case?
Yeah, you isolate them in a separate thing. Okay. So someone asked about the video. So maybe we will just play once before going to the next video. It's a very classical lesion. Okay, so who wants to do the next?
Sir, I can try.
Okay, doctor. Okay. So this is also a very good video. Okay. So, doctor, you are having you're with a 10-year-old girl presenting with respiratory distress. Okay.
Yeah, in this video, can I start, sir?
Yeah, doctor, you have 15 minutes. If you're okay, you can start now. 15 seconds more. Yeah, you can start. What is
And
your observation, doctor?
yeah, in this video, I can see a young girl, a 10-year-old girl, who is probably in the hospital setting. And she does not look dysmorphic to me, but she is in some amount of respiratory distress. And most importantly, she has a chest drain attached to the right side of her chest in the upper ciliary area. And it is draining, as I can see, it is draining some purulent fluid, which is collected below in a water seal drainage. And probably she has, this is a purulent type of pleural effusion, probably empyema.
Okay, doctor. So what questions you want to ask in the history?
I would like to ask about the onset of her respiratory distress. Was it preceded by fever, cough, and what was the kind of cough? Was it dry? Was it productive? The color, amount. I would also ask if she has any pre-existing chronic illness, and I will ask about any in the recurrent chest infection, and how has this affected her sleep? Has it caused any weight loss? Most important, has she come in contact with any open case of TB? And is there, and along with this, is there any swelling of any other part of our body? I'll look for the vaccination scar. I'll ask for whether she was vaccinated with BCG or not, and also about the other vaccinations, mainly pneumococcal vaccination.
Okay, doctor. So what will you examine in addition to the above findings? What else would you like to examine?
I would check her airway, breathing, circulation, the oxygen saturation. Then I will look for especially presence of pallor, curbing, and cyanosis. I'd like to plot her weight and height on age-appropriate chart, see her growth, check for the BCG scar, and do a chest, abdominal, and a cardiac examination.
Okay, doctor. So what do you think is the cause for distress in this child?
The cause for distress is probably the collection that she has developed, the pleural effusion that she has developed. That could have been could be the cause of the respiratory distress, as is evident.
Okay, doctor. So
It could be the associated pneumonia also, severe pneumonia.
okay, doctor. So what might be the cause for this collection? So what is your differential for the collection?
Okay, it could be a complication of a community-acquired pneumonia due to Streptococcus pneumoniae, most commonly. And if it is, if by doing ultrasound we see any loculation, if it's multiloculated, it could be staphylococcal as well. And since it looks purulent and not serous, I would like to keep tubercular later. But in tubercular also sometimes infection does set in, and the fluid sometimes might get purulent. Other than that,
So how do you want to investigate this child?
yeah, I would, since this chest drain has already been done, I will set the pleural fluid for gram stain, physical, chemical, cytological, AFP, gram stain, and EDA, along with culture, and do the basic workup like full blood count and the inflammatory markers and the electrolytes, this child might require fluids. And other than that, blood cultures, sputum cultures should be sent ideally. And rest of the investigations will depend if she has any history of recurrent infection, then I would consider immunodeficiency as one of my differential diagnosis and send IgG-AM.
Okay, doctor. So, how will you manage this child? Suppose it's an empyema.
Yeah, first of all, I would admit the child and inform my consultant and have a multidisciplinary approach involving the team of cardiothoracic surgeons as well. If the child requires a drainage, I would specifically contact the chest team and after sending the investigations and do a preliminary ultrasound to see whether there are any complications. And after that, proceed with the chest drainage. The multidisciplinary team would consult a pulmonologist, the anesthesiologist, the interventional radiologist, cardiothoracic surgeon, as I've already said. Then take care of the airway breathing circulation, give her analgesics for the pain. If she's in oxygen saturations are coming down less than 92, I will give her oxygen saturation as well. I'll give her oxygen as well, then IV fluids and antibiotics, start her antibiotics empirically.
What antibiotics will you choose, doctor?
It depends. If it is a community acquired pneumonia, then I would start her on intravenous coamoxiclav, and if she's sensitive, along with clindamycin. And if it is hospital acquired, if she has had a stay in the hospital for more than 2 days, I would consider giving her piperacillin tazobactam. And if there is a suspicion of TB, then I would of course consult the TB team to if TB can be isolated from her fluid or from any other test and start.
So here, suppose the column is not moving. So what will you think?
If the fluid column is not moving, there could be a chance of obstruction, and we will try to see if there's any obstruction and try to clear it if there's no swing.
Okay. Suppose there is bubbling of the chest tube, what will be in your mind?
The bubbling of the chest tube means there is air and it is coming out. We should never try to clamp a bubbling chest tube and allow the air to come out. That will relieve the patient.
And when will you involve the surgeon?
If involvement, if it seems to be if it is a complicated effusion, which is multiloculated, and if we suspect any other cause of the effusion, and if this child goes on to require surgery, then also we will have to involve the surgeon in case he requires VATS, video assisted thoracoscopy surgery for complicated cases.
Time up, doctor. Actually, 1 or 2 minutes extra over. I just wanted to ask some more questions. But you did well, how you did, doctor, honestly.
Actually, I was in preparation for this. I have there's a conference here in Siliguri. I'm in the respiratory team, so I have to.
Okay.
I have been preparing this respiratory system, so little bit I'm in, but still.
But still, okay, you were able to manage, except some few things. I think others can add. Anybody else wants to add?
Sir, is it a respiratory cause of pleural effusion, or could we consider like hepatic or malignancy or cardiac cause since the child is not connected to oxygen, sir, here.
Doctor, regarding the causes, huh?
Yes, sir, causes.
Yeah, I think the video which we have here, it's a straightforward, there is an ICD tube and pus is there. But I think the MRCPCH exam video doesn't have an inserted chest tube, I think. So there it will be the typical examination findings. So they will be doing the percussion, so the dullness will be there. So air entry will be reduced. So like that. Then they are going to ask you the differential. I think there the cardiac cause, the pleural effusion, then nephrotic or the pancreatitis, all the other causes of pleural effusion in addition to the empyema has to be talked about. But here it
And
is
what is the other dressing that we see below the attached chest tube insertion site? There is another dressing below that costal margin, sir, or near to
I
that
think
costal
that is
margin.
to secure. That is to secure. So
Sir, I thought it was
but you have
given.
to comment. You have to comment on that. But the tube was meant to secure the tube.
Both the dressings are for the tube only.
Yeah, only one tube only. So both the
No, sir.
dressings are to secure the tube in place.
Okay.
Okay.
Okay, sir.
I think one of them asked one nice question. Actually, I was waiting for that only. So that's why I didn't show the X-ray. So the video had an X-ray. I didn't show the X-ray because uh, y- you have to be aware of the whole video actually. So here the video also includes a chest tube inserted. So once chest tube is inserted, then you have to talk about the chest tube. How is the column? Is the column moving or not? So I think Tanushree, you didn't comment about that. So column,
Yeah, I missed out on that part.
yeah,
Whether it was a swing, whether there was swing or not, or
yeah.
whether there was a.
Because that's
I
why
said
the child had distress, na. So what might be the cause I was prompting? So you need to be a bit. You are expected to also consider the complications. So that should be in your mind. So when a chest tube is not moving and a child is in distress, so what might be in your mind? So other than, so we know, so child has a pneumonia that has gone to empyema that can cause parenchymal involvement, distress is there. So that is there, one part. But also you should keep in mind that what if there is a tube block is happening, okay? And what if the child is going in for some complications because of that, okay? So the child, so you have to you should also keep in mind, okay, about
Sir,
tube
can I
block.
see the video again so that this time I can
Yeah,
appreciate that part? I mean, whether.
yeah, I'll show that. No, not distressed. The column is not moving. Okay. So
Yes, there should always be a swing. That should be evident.
so keep that in mind. Complications of the tube blockage that can cause some distress. So and as you said,
What are the answers of other two questions, sir?
yeah, doctor.
Like the bubbling of the chest tube and when to involve the surgeon, sir.
Yeah, bubbling of tube, I think she said right. So if there is a bubbling of tube, probably a bronchopleural fistula has happened. So you're not supposed to clamp the chest drain. Otherwise, you will end up with a pneumothorax. So the child will end up with a pneumothorax. So you should not clamp a bubbling chest drain. And column movement, if there is no column movement, then probably it is obstruction. So you should try to flush and see. And still, if the column movement is not improving, then you have to change the tube. If the ultrasound shows still lot of fluid collection is there, then you have to even reinsert the tube with a fresh tube. So even after flushing, if it is not improving, okay. Then the gravity, so care of the chest drain, I think you can read about that in the guideline. So always drain it in the water bubble, underwater seal, and it has to be below the gravity. So always the chest tube has to be below the level of the child, so that you can talk. Then they might ask you about, I think you didn't mention about the investigations, doctor, imaging investigations. So X-ray, role of ultrasound. So you talked about the microbiology investigations. Imaging investigations also you mentioned. So I will be doing the ultrasound to look into the collections, to look into the loculations. And if frank pus is there, if loculation is there, then in the management, you should talk about adding urokinase to remove the loculations. So in addition to the antibiotics. And if it is a fresh case of you are about to insert a chest tube, you should also talk about the clotting screen, because you are going to insert the chest tube. So you have to make sure that there is no coagulopathy is there. Good thing that she was talking about immunodeficiency and workup. If it is going to be recurrent empyema, recurrent pleural effusion, you have to rule out the immunodeficiency. So that part was good. And I think chest X-ray, that's part, the regular part. CT chest. So when to do the CT chest, you should keep in mind. Suppose even after 3 days of chest tube insertion, child is not improving, then you have to do CT chest. Or a cavitation or fistula is forming, or you are worried about malignancy. So if you are worried about malignancy, then you have to do the CT chest. Okay. Then any other doubt, doctor, or we'll move on to the next.
So when surgeon has to be involved.
Yeah, surgeon. So if the child, even after on ICD tube, child continues to remain, that is, it's not resolving. So the problem is not resolving. The child continues to be septic. That is, child continues to have fever and all. Then loculations is there. So then it's time for the surgeon to have a look for VATS. So video assisted thoracoscopic surgery, so that the additions and all is removed. So now the trend is moving towards early VATS. So you remove all the additions, you remove all, drain out all the pus collection. So the fever will start improving. So most important is non-resolution of symptoms, continuing of the septic. Child is still septic and effusion is not resolved. The empyema is not resolved in spite of maybe 3 days. I think then you have to involve the surgeon, mainly for VATS. So he is going to do a video assisted thoracoscopic surgery and all the additions and remove the drainage. Okay. So we will move on to the next. I think Anjali, you missed out. You want to do this one now? Third one.
Yes, sir.
Excuse me, sir. Who will insert this chest drain regularly, like in NHS? Because in our country, pediatric surgeons are doing the chest drain insertion.
Yeah, I think here in the multidisciplinary team, they are talking about the anesthetist. So for the anesthesia, then the cardiothoracic surgeon. So we have to involve the anesthetic and cardiothoracic as part of the team. I think for the chest tube, you involve the cardiothoracic surgeon. That's the anesthetist.
Not pediatric surgeon, right?
Yeah, not pediatric surgeon.
Okay, thank you.
In NHS, I think they have a chest team
Yeah,
who does this.
chest team. So we can, as a whole, we can say chest team. Yeah. Okay, doctor. So we will move on to the next. Anjali can do. This is also a quite recent recall only. So, doctor, you have 3 minutes time. The child is presenting as a 2-year-old child with swelling in the neck. Okay. Take 3 minutes of your time.
Okay. Hello.
Yeah, doctor, you're ready?
Yes, sir.
Okay, still you have
Sir,
actually one more minute, so you can prepare.
sir, then I will wait for 1 minute. I prepare.
Yeah, you can prepare. Okay, doctor, you can start.
I see a stable, active, alert child with a unilateral swelling in the neck, almost the size of 2 cross 3 centimeters. She appears to be not in pain and interacting with mother. It has not affected the movement of the neck. So my differential at this point would be a cervical lymphadenopathy.
Okay. Okay, doctor. So, what questions you will ask in the history?
So in the history, I would like to know the onset of the swelling. How has the swelling progressed? Whether it has increased in size during any point of the time the swelling was painful. How whether there was any skin color change over the swelling, and has it caused any other dermatological signs or symptoms like any rash elsewhere? Has it caused some dysphagia? Has the child been sleeping well at night? How is the appetite of the child? Does the mother have noticed whether the child is losing weight recently? And any other system involvement, like a respiratory system involvement in the form of a chronic cough, and any history of contact with chronic diseases like tuberculosis, any pets in the house, whether the child has been got any cat scratch, and any nighttime awakening with severe bone pain. Any history of any travel for the child, and any lumps or bumps elsewhere in the body, history of any fever, evening rise of temperature, night sweats, any change in voice, like hoarseness in the voice of the child, or any nasal change in the quality of the voice, any other symptoms like conjunctival involvement, that's it.
Okay, doctor. So what examination you want to do?
So I would like to do a general examination of the child to know the vitals of the child, then followed by a local examination of the site, about the size, the skin over the swelling, the mobility, how is the swelling feel, whether it is firm, hard, or soft, and how it has affected the nearby neurovascular structures. And I would like to palpate the other cervical lymph nodes if at all they are enlarged, other sites of lymphadenopathy like axilla, groin, epitrochlear area. I would also go for examining the liver and the spleen for any hepatosplenomegaly. And I would look for a BCG scar. Uh, I would look for a dermatological examination for peripheral signs of tuberculosis, like dermatological signs of tuberculosis, and uh, oral cavity examination to look for dental caries, and tonsillar involvement, any posterior pharyngeal wall ulcers, lesions. And I would also like to go for a complete respiratory system examination and ENT examination in this child.
Okay, very good. So, how do you want to give a differential diagnosis based on the duration of lymphadenopathy, doctor?
So in this child, based on the etiology, it could be an infective, inflammatory, or neoplastic. Based on the duration, like less than 2 weeks, it could be acute infective causes or inflammatory causes like Kawasaki. Infective causes, I would include a streptococcal, staphylococcal infection, and inflammatory like Kawasaki. And subacute causes like 2 to 6 weeks could be a reactive lymphadenopathy or an upper respiratory tract, and a chronic cause, malignancy, I would consider, and tuberculosis can come in like subacute or chronic. Sir.
Okay, doctor. So, how do you want to investigate? So, when will you do urgent investigation, doctor?
If the child is presenting with all the warning signs of suspected malignancy, I would go for urgent investigation like night sweats, loss of weight, loss of appetite, evening rise of temperature, or any close contact with tuberculosis. Also, I would go for urgent investigations. Like, and also in malignancy, I would also go, like bone pain is there. We have to urgently investigate, and a hepatosplenomegaly would be pointing towards malignancy. And a purpura or petechial rash somewhere. And if we go on for investigations, is there any change in the cell lines, then it is more suggestive of a malignant cause. Um,
Okay.
so,
Suppose this child's lymph node has been there for more than 6 weeks.
yes, sir.
So, how do you want to investigate?
So, I would like to go for the blood investigations, like a complete blood count, a peripheral smear. In the peripheral smear, if it is malignancy, I am expecting to see atypical cells. And I would do an ESR. In tuberculosis, I am expecting a raised ESR, and I would go for a CRP. In infective causes, CRP is supposed to be high. Malignancy also, the CRP could be high. And I will go for imaging investigations. I will do an ultrasound of the neck to know the site and depth of involvement. It is also for the diagnostic and investigative purposes. Like diagnostic purposes, as I told, the depth of the lesion, investigative to do an FNAC. ultrasound guided biopsy or of this lesion to examine. And I would also like to go for see if I'm suspecting like a EBV, I would like to go for an EBV serology. That's it.
Okay, Dr. Okay. So, yeah, suppose the child is not, it's not resolving, the node is not resolving, and all your investigations are coming negative. So, what will you do, doctor?
So like in chronic, sir.
Yeah.
So after the biopsy also, if I'm not getting
Yeah, after
positive result,
biopsy, I think you will get. So, yeah, you need to do the biopsy of the
I
node.
start the antibiotics form of sickle, sir. And
Yeah,
trial of antibiotics can be given for 2
can
weeks.
be given. Yeah, time up, doctor, time.
Thank you, sir.
Yes, how you did, Anjali?
Sir, okay, thanks, sir. But I am not so sure, sir.
Yeah, but you were able to remember a lot of things. I think you read the guidelines, right?
Yes, sir.
Yeah, I think you were able to answer the way. So that's the most important thing. So in video station, if it is coming from the guidelines, so the pediatric guidelines, so all the questions will be from the guidelines. So it will be very easy to walk through. But if you don't know, you have not read the guidelines, even though you will be reasonably right when you are talking. So because but the answers which they are expecting might not be there. So that's the thing. So in video station alone, if it is in the guideline, you have to prepare from the guideline. So it will be easier for you. Okay. Anybody else wants to add to what Dr. Anjali has said?
Sir, I have a doubt, sir.
Yeah.
So
Could
she
it be
said,
something other than
1 second. She said,
Huh.
like, you asked to, what is the cause of urgent investigation? You had asked, na?
Yeah.
In what case you will do urgent investigation?
Yeah.
If clinically these lymph nodes appear matted and skin is adherent to it, these are definite signs, danger signs. This could require urgent investigation.
Yeah, that's what this is a question taken straight from the guideline. So when will you do urgent investigation? So if you read that and you tell you are through. So that is the thing. I will tell you. So not an issue. Dr.
sir? My
Anjali,
doubt is, could it be
uh,
something other than cervical lymphadenopathy, sir?
yeah, that
In
also
this
I was
child.
expecting because you said my differential diagnosis and as an ST3 and no, you're a resident, no, so you need not give a single diagnosis. So after that only you are going to take the history, then you are going to examine, then only finally going to say. Because on looking at how can you straight away say that this is a node? What if it is a branchial cyst?
Yes, sir. Branchial cyst could also be a possibility if it was present from the, like, if it was present
Yeah,
like from a longer duration.
yeah. But here I
That you
think
will know only from the history, na?
yeah, I think they will be saying only swelling in the neck. So outside
Yeah.
the background will be child presenting with a swelling in the neck, and there will be a swelling in the lateral side. So better, even branchial cyst has been kept in the MRCPCH exam. So if we take straight away our course as cervical lymphadenopathy, no, then we might miss the bus. We might lose marks. So if it is kept as branchial cyst, then we will be in trouble. So it's better to keep that simultaneously, and just one or two things will rule out just while palpating
Virotitis.
whether it is cystic or not, and transillumination. So that things are more than enough actually. Okay.
Sir, like how do we enlist these causes? Like first we keep cervical lymphadenopathy or lymphadenitis or any branchial cyst or any other thing like thyroid swelling? How do we enlist just on the basis of this video?
Yeah,
Or we
in
can
this, yeah, in
uh,
this we are very pretty sure that it is lymphadenopathy. Yeah, accepted. But still, keep a differential diagnosis. Keep a second differential, at least the branchial cyst. Keep your branchial cyst here, and sometimes it might be in that border of parotid also. So we can also keep a and you need not
Endotracheal
give.
forms.
You need not give a differential straight away. No one is expecting you to give the differential straight away. First, you describe your observations. So, whatever you are seeing, you describe it. Then, I would like to gather more information in the history and examination. So, only after the examination, you will be giving a differential diagnosis. Okay. By the time, many times the examiner might give you some clues. Or if the examiner doesn't give the clues, then you can tell, sir, these are the differential I am keeping. Based on the history and examination, I would be ruling out others. Suppose it is an acute in onset, it is not present from birth, then I will be ruling out branchial cyst. So like that you have to tell. Okay.
So, in the
Yeah, doctor.
station, in the exam, it is better not to give the differential diagnosis on your own and wait for the examiner to ask you, isn't it, sir? Rather than saying this is my differential, just describe the video and wait for his next question, or is it?
Yeah, better that we can do. Uh, we can answer the questions what the examiner is saying. So the examiner will be saying, what are your observations? So there he is not expecting you to give the differential.
Yeah,
He is
exactly. It's
saying
just
what are your observations. So you just whatever you observe, you tell the observations. Then suppose he says what's your differential, then you give the differential. Or mostly many examiners will start with you, okay, what do you want to ask in the history? What do you want to ask in the examination? Then they will say, okay, what's your differential? Then he will say, okay, assuming that this is a firm swelling, assuming that this has been a short duration, what's your top differential? So then you have to tell the top differential. Then based on the top differential, you are going to do the investigations. So once you come to investigation, somewhat they will tell you the diagnosis. You cannot be going for investigation of the whole differential. Okay. So there the examiner might open up usually.
so firm and short history. What will we give? Firm
Yeah,
and short history.
yeah, doctor, what?
Uh, Firm inconsistency and short history.
Yeah, once it is firm and what is the duration? So that's what we were
Short,
asking, no? We were
short.
classification. So once you look into the guideline, so you have an acute, so acute in onset, then subacute. So acute is, I think that's only 7 days. Then you have a subacute. Subacute will be less than 2 weeks. Then you have the chronic. So in acute, you have actually separate unilateral and bilateral. So in acute, unilateral will be your streptococcal, then Kawasaki, then cat scratch. So it's all given in the guideline. So when it comes to bilateral, then your viral will come back. So Epstein-Barr virus and CMV virus, it will be bilateral. Then the subacute will be your atypical mycobacteria and tuberculosis and toxoplasmosis. So these three will be your subacute. Okay. Then the chronic only your malignancy will be in the picture. So based on that you. So is it acute? Then acute means is it unilateral or bilateral? So based on that you give your differential. Okay. And if I want to give the feedback, mm, so first feedback was give a broader differential. Don't go with straight away cervical lymphadenopathy.
Okay, sir.
Then in the history, uh, I think common is common. So whenever you have a cervical lymphadenopathy, the common will be your throat infection. So
Okay, sir.
streptococcal pharyngitis, no? Streptococcal. So you should have asked about any history of throat pain. Did you ask that, doctor?
No, sir, I asked fever
Ear
only.
pain also, no, sir. We can ask ear pain also, ear discharge
Yeah,
and ear
yeah,
pain.
ENT related problem. Dr. Akash, yeah, we will share you the guideline, doctor, in the group. Definitely, we will share you in the group because that is the core for video station, no? So you have to follow the guideline. Then only you will be safer, because the question is clear. When will you do urgent investigation? That is a typical topic in the guideline. So like that only they will ask you. Okay. But many questions you try to address, doctor. So that I'm very happy. On the go, you are able to ask. So you try to ask about the onset course duration. So that was good. Then whether there is any pain or not. So that's very important. The whether it is TB or not. So that fever, weight loss, and sleep affection. So that part was very good. Pet contact. So that is very important. And for TB, actually travel here, they all expect UK, no, they expect whether you have traveled to an endemic area, and where, and any pets. I think the cat scratch is very important. Then the red flag. So any lymph node, do not miss the malignancy. So make sure you asked about the bone pain, then petechiae, so any bruisability, so those part, any pallor, so those things you have to ask. So nighttime awakening. Then Anjali, did you explore about Kawasaki?
Sir, I asked any eye involvement
Yeah,
and
only
the
one
posterior
you
pharyngeal
just
wall
touched
involvement.
and go on. So ask
Yes, sir.
fully. So eye involvement, mouth involvement, any skin rash, any hand swelling.
Skin
So
rash, I
like that,
meant that only, sir. But I didn't
yeah,
ask.
quickly ask
I didn't
all
say the
the,
Kawasaki word.
yeah, quickly ask all the points. Don't stop with
Okay, sir.
only conjunctivitis, okay? Because
Okay,
that
sir.
is a red flag. So in this video station, for the lymphadenopathy, they're expecting you not to miss out these three things. So one is mycobacteria, okay, tuberculosis and atypical mycobacteria. Two is Kawasaki. So unilateral lymphadenopathy. So this child is having a unilateral lymphadenopathy, short
Okay.
duration, Kawasaki will be there. So whether it is painless or not. So it will be a painless swelling. So painless swelling. So how about the other involvement? So lymph node, how about eye change? How about mouth change? What is happening to the rash? How about fever? How about hand change? So that all you have to ask, because they are expecting you not to miss the Kawasaki. Then the chronic, you are expected not to miss the malignancy. So that you are asking about the bone pain, lumps, and I think you did ask about that. So then you almost gave the differential nicely. So maybe unilateral and bilateral you can put together. So that would be better. Urgent investigation also you told very well related to malignancy. Based on size also, you remember, ma. So in the guideline, no. So based on the size and duration also, they talk about urgency. Suppose the node is in the suprasternal and supraclavicular. So then that is probably malignancy. So you have to do urgent investigation. So if the nodes are supraclavicular or suprasternal, urgent investigation. If the node is increasing beyond 2 weeks size, then you need to do urgent investigation. And if the node is more than 2 centimeter, even after 6 weeks, then also you have to do the urgent investigation. And if it has not resolved even at 12 weeks, less than 1 centimeter, then again urgent. So based on size and duration, also urgent investigation criteria is there. But the one which you told was good. So if there is any petechiae, purpura, hepatosplenomegaly, night sweats, fever more than 2 weeks, you are suspecting malignancy, then urgent investigation you have to do. So that part was good. With regards to the investigation, I think for more than 6 weeks, you have a separate chart. For acute, you
So can't hear you.
Sir, I can't hear you.
Yeah, doctor, give me 1 minute time, doctor. I got disconnected. Okay. Hmm. Just a minute, doctor. I will join. Okay, doctor. We'll move on to the last topic. So who wants to do, doctor, the last topic? The last video is actually often asked. So repeatedly they keep asking. So
Okay.
anybody wants to volunteer? Sangeeta, doctor?
Yes.
Okay, doctor. You're from which place, doctor?
Uh, Delhi.
Okay. You're able to see the screen, doctor?
Yes.
Okay. So the scenario is 1.5-year-old child presenting with breathing difficulty. Okay.
Okay.
Take 3 minutes time.
Okay.
Just going to change your trachea, okay? No, it's going to be very quick. Emily's here to help as well. It's okay. Okay. Change your trachea, okay? No, it's going to be very quick. Marie's here to help as well. It's okay. What we say? Change your trachea, okay? No, it's going to be very quick. Marie's here to help as well. It's okay. Okay. Change your trachea, okay? No, it's going to be very quick. Marie's here to help as well. It's okay. What we say?
Yes, I'm ready.
Okay, doctor. So you can start. So what were your observations, doctor?
So in this video, I can see 1.5-year-old child, most probably in a hospital setting. Child is looking not in a distress. There is a tracheostomy tube inserted in situ in a trachea. And I would like to plot child on a, appropriate height and weight centile chart. And on this video, I can see two medical professional are there and wearing gloves and doing the procedure, which is changing the tracheostomy tube. And while removing tube, there is some collections is there, and they removing and changing again and keeping again in a position. Meanwhile, I could not see any cyanosis or any distress. However, there is a mild discomfort while changing the procedure, and I can see child is looking well in all over the procedure.
Okay, doctor. So what history you want to ask in this child?
So first of all, I would like to ask a detailed history when this tracheostomy tube is inserted. Is there any difficulty in feeding, and how frequently you are changing the tube, or is there any any assistant of taking care about the tracheostomy care is explained to the family, and how they are managing about that, and is there any long term chronic illness for they are doing a follow up, and how many teams they are following, is there any recurrent infection in the chest, or a child is vaccinated up to age, or any special vaccination they are taking.
Okay, doctor. So what examination you want to do? in this child?
I would
Okay.
like to do detail. I would like to do general physical examination, including vitals, respiratory rate, saturation, and also anthropometry assessment of the child, and respiratory examination, as well as the ENT examination and throat examination, cervical lymph node assessment, and detailed tracheostomy tube assessment. Is there any discharge or any collections or any blockage in the tube?
Okay, doctor. So what you are going to look for the tracheostomy tube?
First of all, I would like to check for its position. Is there any sound is present from the tube, or is there any surrounding area having any infection or any inflammation, redness, or any pus collection or something is coming out from the tube?
Okay. Okay, doctor. So, what are the indications of tracheostomy, doctor?
First of all, it is a long-term requirement of the ventilatory support. If there any structural malformation in the uh, root of the initial airway, and if it is a child is not able to breathe properly, and it can be in an emergency life-saving procedure.
In an emergency also. Okay. I can do. Okay, doctor. So what investigations you want to do?
First of all, I would like to do chest X-ray for any abnormality of recent infection, any pneumonia, and other pathology in the chest. I would like to, if child is in a distress, then I would like to do EVG and full blood count to check for any sign of infection, ESR, CRP. And if it is a pus coming surrounding the tracheostomy tube, then I would like to do a pus collection and culture sensitivity from there, and blood culture if it is a sign of infection is there.
Okay, doctor. So how do you advise the parents regarding care of the tracheostomy tube?
So first of all, I would like to involving my consultant and a multidisciplinary team involving the ENT team and also a tracheostomy nurse, as well as giving the mother and parents to what are the indications of tube and how you have to take care, what are the feeding step you have to take, how should you give feed properly, and how frequently the tube will change, and if it is any pus coming out or any surrounding redness and any difficulty in breathing with the tube, or any change in skin color, or any bluish lips, and any increase work of breathing, then immediately come back to the emergency.
Okay. Suppose a child is coming to the emergency to you with respiratory distress, breathing difficulty. So what all you assess and how will you manage?
So if this child is present with difficulty in breathing, first of all, I would like to see for any sign of the blockage of uh, tube blockage, or any sign of any with a history. I would like to assess for any recent increase in the work of breathing or any foreign body inhalations if a child is taken, because this age group is more prone to the foreign body aspiration, and I would like to see for any changing work, any breathing pattern.
So what will you do?
So I would like to involve my consultant, and I will manage the airway breathing circulation. And if there is apparent blockages there, then I would like to involve the ENT team. And if required, then I would like to replace the tube with the involving the specialty team and my consultant.
Okay, okay, doctor. It's time up. So, Sangeeta, you have been practicing already.
Yes, sir.
So how you did?
Actually, it was sudden, so I never thought that this video can be possible.
But for the sudden thing, I think you did well. Okay. We are happy.
Thank
But
you, sir.
what what all else? Because this is a common scenario actually. It's roaming around, and video is one which will keep on getting repeated. So this video will keep on getting repeated. I think that child is a SMA child. So the video which MRCPCH is showing, na? So that is an SMA child. Here also, when you look now, so the child is not moving the limbs much when they were
Yes,
changing. Did you see that?
yeah.
So did you mention that?
Oh, I forgot to mention. Initially, I was
Yeah.
thinking that there is a alert
The
look
paucity
and
of movements. Huh?
yes, yes.
Yeah. So the child is alert, but there is a paucity of movements. Na? So I think initial observations, that all you have to mention. And some amount of dysmorphism is also there.
Yeah, I mentioned, I see there is a frontal bossing and low set
Yeah.
here, but
Yeah.
I did not mention because I'm not sure because
Yeah.
the
But
child.
they will not expect you with the diagnosis, but the
Okay.
observations, whichever is there, you tell that. Okay. And anybody else wants to add to the points?
Sir, I have a doubt, sir. This child is actually vocalizing
Yeah.
on a tracheostomy, sir.
Yeah.
Sir, is that possible, sir? Is it because they're changing and they're occluding that orifice the child
Yeah.
is able
Yeah.
to?
The child is trying to do, but exactly words are not coming out now. That much I think will be
But
possible.
in a tracheostomy, unless we occlude it for that hole, we cannot produce a sound. Is it so,
But
sir?
the voice, it's only the noises are coming. I would say that it's not exactly the speech. Speech is not
Okay.
coming. Only some noises are coming. So I think that is possible. But the child may not be able to speak with tra- the tracheostomy on. So here only the noises are coming.
Only
So when
whispering is possible, sir, when they have a tracheostomy.
Yeah, some noises that can come. So the child is
Just
showing
like
some
whispering.
discomfort. The discomfort alone is we are able to make out in the form of some noises, but it's not a speech actually.
and sir, about the causes, what all the things should we include in the list? Like why was the child put on tracheostomy for that question, sir?
Yeah, I think that indications of tracheostomy. So that I think she almost told. So one is the airway. So airway obstruction. So it could be the congenital malformation. So when the airway is small, no, so subglottic stenosis. So the child might have been ventilated and gone for subglottic stenosis, or birthwise itself some airway glottis or severe laryngomalacia or the syndrome type. So the child can be having like Piri Robin, Treacher Collin, and all those. No, so basically the airway abnormalities which is not allowing for the airway. So there you have to give the tracheostomy. Then next is any child who has the neuromuscular, as in the SMA and myopathies. So there also you have to go for the tracheostomy. So those two you have to keep in mind definitely. Then third, suppose a child who is on prolonged ventilation. So the child is ventilator dependent. So best example will be your premature baby who is having bronchopulmonary dysplasia. So the child will be prolongedly ventilator dependent. So there also you have to go for the tracheostomy. Plus, some more causes might be like severe GERD. Suppose the child has a severe GERD and the risk of aspiration is happening often. So, in order to protect the airway, also they do the tracheostomy. Then you can talk about some acute causes also. Suppose the child is going for anaphylaxis or your epiglottitis, na? So croup and epiglottitis, they are all acute. Anaphylaxis, angioedema, they are all acute causes where you have to do the tracheostomy. So you have acute causes, you have a chronic causes. In chronic causes, it is the airway issues or it could be the neuromuscular issues, or it could be the sometimes prolonged ventilation. The child might be needing prolonged, like in GBS. So the child might be at GBS. You might be needing for a long period ventilation. So then again you have to go for tracheostomy. Then to protect the airway secretions, suppose there is severe GERD, there also you have to go for tracheostomy. And I think Srikanth has written, yeah, burns as an acute burns. Then obstructive sleep apnea is also an indication. I think Srikanth has added good number of extra indications. Obstructive sleep apnea, severe obstructive sleep apnea, then you have to go for, because the upper airway is causing obstruction, sleep apnea. So you have to go for tracheostomy. Then your prolonged intubation, yeah, neuromuscular myopathy, subglottic. So that all we discussed. Okay. Any other questions, ma?
Advice, sir, advice. And emergency also, you have asked emergency.
Yeah, in this, so the child is coming in distress. So I think she told one point is very nice, plus solution also you tell. So the tube is blocked. So the child is coming for distress, tube is blocked. So there only you have to look, feel for air movement. You keep your hand and see whether air movement is happening. So look, feel, and listen. You can listen, you can even auscultate and see whether the breath sounds is coming or not. So that will be the tube block. So immediate solution will be the saline. So you do the, try to push saline, try to do the suctioning, and if still not possible, you replace the uh, tracheostomy. So you replace the tracheostomy tube. Okay, so that will be one. The next will be the position. So that has gone to a different position, displacement, and so that will be the second reason. So displacement. So for the distress. Then the third one actually, so because
Yes.
of these infections, so the child is on tracheostomy tube and secretions and infection, the child can go in for distress because of the tracheostomy tube causing infections. So infections, displacement, blockage, and sometimes you can end up with
Sir,
the child is on ventilator, no? So you should also not forget that. So child can easily go in for air leaks. So pneumothorax. So that also you should keep in mind. So pneumothorax. So whenever, so that you have to auscultate, asymmetry in movement. So then you have to go for the needle thoracentesis quickly. Okay. Then the respiratory infection antibiotics you have to give. Plus the most important will be your obstruction and displacement. So do not forget the obstruction, displacement, infection. Then the complication of the ventilator. You can end up with pneumothorax. So that is the important things. Then what advice, na? So advice will be for the care of the tracheostomy. So I think that the parents should know how to take care. Like daily, they should be cleaning the surrounding area so that that should not get infected. Surrounding area, they have to apply the dressing so that it soaks the secretions. So that is very important. Then suctioning actually only whenever it's required. So whenever you feel secretions is there, whenever you feel the saturation is going down, so there all you have to put the saline and do the suctioning. But suctioning has to be gentle, and suctioning has to be done only while removing the suction tube, not while inserting, and it should be only for 5 to 10 seconds. So that all you have to check, and make sure that the tracheostomy ties,
sir,
the
pardon.
ties.
What you have told, sir, just now? I didn't get you, sir, actually.
So
Suction
the
by inserting.
only while removing you have to do the suctioning. So you insert the catheter for suctioning, na? So
Yes,
while
sir.
inserting, you should not on the suction. While
Okay, okay.
withdrawing only, you should do the suctioning. So that only I was saying. Then the tracheostomy ties, no, that thread. So that should be proper. It should not be tight enough. Then you have to tell the parents about the saturation monitoring. So the danger signs, and they should know how to change the tracheostomy tube. They should have a tracheostomy tube, spare tracheostomy tube. They should even know the basic life support. They should have a bag and mask with them. So in case of any issues, immediately they should stop the ventilator and start giving bag and mask and call for help. So that much they should be taught. So how to take care of the tracheostomy tube and the danger signs. Okay. Then major what else? So tracheostomy indications we discussed, and in the history, you have to ask about how long the child is on this tracheostomy, how long, and also concentrate on the possibility of infections. How will you ask history of infections through the tracheostomy? Secretions, the
You
quality
can
of secretions. No?
smelly secretions coming from the tracheostomy sites.
Yeah, and the quality of secretion also. Is it becoming thick? Is it becoming green and purulent? So that all you have to ask in the history. So those parts will be helpful. Plus, in addition, in history, do not stop with only the tracheostomy indication and the chronic disease. Also, we will be talking about the neonatal history, what is happening, the NICU history. There might be a prolonged stay, the child might be a preterm. So, what is the birth history you have to ask? Then, how is the child's feeding? So, they will have issues with the feeding. So, how you are able to feed? Is there any reflex happening? Okay, and how is the child growing? So those all they should talk about. And so far, how many complications have been happened? So with the tracheostomy tube and the mechanical complications. So that all you have to ask in the history. Okay. Then in the examination, I think the regular airway, breathing, circulation, vitals. So that part you are going to check. You are going to check the ventilator settings. So there is a ventilator. So ventilator settings and SpO2. You're going to check the tracheostomy tube. So local examination is very important. Then the RS, respiratory system examination. So make sure there are no crepitations, make sure infection is not there. So that you are going to check. Then associated CVS examination also important. Even development assessment you have to do. So in the examination, what all you are going to check. So local examination of the tracheostomy very important, especially for the infection. So look in the surrounding skin, how whether it is redness is there or not. So that all you are going to tell. I think that's it. So investigation. So I think the SpO2 capnography, since ventilator is there. Then chest X-ray, if the child is in distress, the respiratory distress, I think then chest X-ray becomes important. Then if the ventilator is there, ABG we can talk about. Then if you suspect infection, then the secretions, gram stain and culture, so that you can talk about. Then you can extra investigations, now you can talk about bronchoscopy also in liaison with the or in discussion with the pulmonologist. So to look for granulation tissue, etc. you can do. Okay. Any other doubts, Doctor? I think all the videos were good actually. Most of them are recalls. Video session is only one. You can get it again and again. So I'm very sure in this four, I think one might suddenly pop up. So you might get a tracheostomy tube or you might get Steven Johnson. So high possibility. So keep preparing for the videos. So any other doubts? Or we shall wrap it up. And we are regularly practicing in scenarios for the intensive course. So all those who are interested, you can contact us for the regular intensive course. So we are doing practice sessions like this regularly. So you can contact us. We are always here to help you. Thank you.
And
Thank
what about mocks, sir? Are you doing any online mocks or physical mocks? Will you be doing? If
Yeah,
we get
doctor, as the exam comes, I think still time is there, na? So as the exam comes, we will do the full mocks. So
okay.
So the videos you showed, like SJS was not from the guidelines, and so is tracheostomy. Sir, about
yeah,
SJS, do you have some material that you can share that could be
yeah,
helpful? So
doctor. In the group, I
that,
will share you, doctor, for tracheostomy and Steven Johnson syndrome. I will share. Yeah.
Thank
sure.
you, sir. Thank you.
Thank you. Thank you.